So here you are watching revision adenoidectomy in an 11-year-old child. The reason for performing surgery was tonsillectomy, but also the post-nasal drip. So you can see the earlier surgeon has removed the superior border completely, so there is no recurrence over here. But the posterior border is not removed completely. So I am removing the lymphoid tissue from the posterior boundary of the adenoid, posterior and lateral. So let me first do the first layer and try to, this is the superior boundary, the periosteum below the sphenoid bone. And as you will go in deeper over here, you'll see the posterior boundary, which is the buccopharyngeal fascia in a moment. So what was looking as adequate surgery, now you see how much of tissue was still there to be removed. And this was done by a senior surgeon known for sleep apnea. Now you see that's the posterior boundary, the buccopharyngeal fascia. You see that? That's the buccopharyngeal fascia. I'm not going to open up the fascia, I'm only going to define the fascia. Can you see? This is the fascia. All this lymphoid tissue has to be removed in order to complete the surgery. This is the inferior boundary, which is the Passavant's ridge. The child has traveled almost 1600 kilometers. So it's our duty to do a complete work so that there is no residual symptom, residual problem left. The depth, the third dimension that we call, is the most important. Now that's the posterior boundary, buccopharyngeal fascia, defined almost everywhere. I'll go for my lateral boundary. So the lateral boundary anteriorly is the torus tuberous, and there is some lymphoid tissue here. I am remaining 4 to 5 millimeter away from the eustachian tube and only removing the submucosal lymphoid tissue, which is the lateral boundary anteriorly. And I'll follow the trajectory and go to the lateral boundary posteriorly, which is the buccopharyngeal, which is the fossa of Rosenmuller. This is the fossa of Rosenmuller. This is the superior boundary. That's the fossa of Rosenmuller, the lateral boundary posteriorly. And you can see how much of tissue is still lying over there. That gives the postnasal drip and earaches and all those things. So we need to remove the posterior, the lateral boundary also completely. This is the bulk of the lymphoid tissue. I'm now behind the torus tuberous and removing the lymphoid tissues completely. That's the inferior part, the Passavant's ridge area. When you go laterally, you have to be careful about any vessel which might surprise you. Therefore, will not do anything blindly. And in the extreme depth, you might coagulate rather than ablating. So this is the boundary of the adenoid on the left side. Now I can see a lot of things from here only. You might have realized that I have not taken up out my scope even once so far. Whatever I can see very clearly, that's the midline. A lot of tissue was pending in the midline. So if your scope is fogged, you can just clean it up on the tissues, or you can put some saline. It's important to remove tissues till the boundaries. Otherwise, your surgery remains incomplete. And at the same time, you should never cross the boundary, or then your complications start. Now, I may have to go in from the right nostril because I cannot see very clearly here. That's the fossa prosumber on the right side. Whatever is very clearly visible, I am doing. All right, that's our inferior boundary. Now, let me go in from the right side, right nostril. No significant deviation of the septum in this case. Can you pour some saline system? Thank you. Thank you. So, as you can see, that's the eustachian tube. On the right side, a decent work has been done on the superior boundary as well as the lateral boundary anteriorly. However, there's a little bit of lymphoid tissue which I am removing and following this trajectory behind to the fossa prosumber. And there's a lot of tissue here which I need to remove. So, was it a recurrence? No, it was a residual adenoid. If you remove the adenoids completely, they do not recur. It is the residual adenoid. Can you see the fascia very clearly? I have not opened up the fascia. I have just reached the fascia and defined it. Now, trying to remove the lateral bit very carefully because you can get some vessel from the lateral side. Always be very careful in the lateral part. If there is still some lymphoid tissue over there in the lateral recess, you can simply coagulate it. Suppose if this is the area and you do not want to ablate, you can coagulate. But here, I am very sure, so I am ablating it. Ablation obviously will completely remove the tissues. All right, but you can always coagulate the last layer if you are not very sure about the hemostasis in that area. Even coagulation will work to a great extent because you will take away the live tissues. And see, the moment you go very close, you might open up the muscles, which will be painful. So it's not recommended to open up the muscles and inflict pain. Now, this part is pretty alright, so my surgery is almost complete. So I'll just show you the other side once again. Practically no bleeding. Can you pour some saline, sister? Thank you. And you can see the complete adenoidectomy. And if you want to, suppose if there's a little bit of lymphoid tissue, you can simply coagulate. Alright, the last layer you can simply coagulate. If you do not want to take any chance, this last layer can be coagulated. Now there is absolutely no question of a regrowth, so there is no live lymphoid tissue left. Alright, 1 or 2 millimeter layer can always be coagulated. Thank you for watching.